Thank you, everyone, and thank you for the committee for letting us presenting our article. It's about lymph node yield as a prognostic factor in clinically node negative oral cavity squamous cell carcinoma. I'm Dr. Ahmed Altuwaijri, Head and Neck Oncology Fellow at King Fahad Medical City and King Abdulaziz University Hospital in Riyadh. So for oral cavity squamous cell carcinoma, it's accounting for like 2% of all cancers. Factors including age, gender, and primary site of the tumor, depth of invasion, and lymphovascular invasion also was a prognostic indicator for oral cavity. Cervical lymphadenopathy is one of the most important prognostic factors. So the total number of lymph node retrieved during the neck dissection constitutes the lymph node yield. Previous studies have reported an improved prognosis and survival with higher lymph node yield, as it increases the probability of resecting the potential tissue with occult disease. But still, it's an evolving evidence. So we conducted an analytical retrospective observational study, included all patients treated for clinically node negative, only negative oral cavity from 2012 till 2020. We excluded all patients with clinically positive nodes. Patient demographics, site of cancer, TNM staging, and the types of treatment and number of lymph node dissected, and histopathological diagnosis and recurrence were studied. Considering the clinically node negative staging, all patients underwent supraomohyoid neck dissection, which is level 1, 2, and 3 lymph nodes. Our study comprised of 40 patients, clinically and 0 patients who underwent treatment for histologically diagnosis of oral cavity squamous cell carcinoma. Those are the factors that has been studied. The mean lymph node yield in our study was around 38. We observed recurrence only in 4 patients, which account for like 10%. In other studies like the Cortia et al. Conferred an improved overall survival of patients associated with higher lymph node yield. So higher lymph node yield acts as a diagnostic aid for the accurate pathological staging of the neck. Also, it increases the likelihood of removing the occult metastatic disease. Also, it reflects on the quality of care of the surgeon and the institution, resulting in an improved outcome. Butcher et al. Reported decreased survival rate and increased risk of loco-regional recurrence with the lymph node yield less than 18. And Co et al. And Lumio et al. Observed increased survival in N0 patients with more than 16 and more than 21 lymph node yield, respectively. Cho et al. Reported 23% of local recurrence and 12.8 regional recurrence and 7.7 distant mets. In our study, the overall lymph node yield did not affect the recurrence rate. The recurrence was comparatively less than the other studies with a frequency of 10%. So recurrence was present only in male patients, of whom 3 of them had tongue cancer and 1 had cancer of the buccal mucosa. Recurrence was noted also in patients with a stage 2 and T4, T2 and T4, and 3 of them had radiotherapy post-op. However, there was no significant association between patient tumor recurrence, tumor characteristics, and adjuvant therapy and recurrence. The findings of our study imply that good neck dissection and thorough sampling of lymph node increases the prognosis of patients. Despite the absence of specific guidelines concerning the optimal number of sampled lymph node, selective neck dissection with a good quality will no doubt impact the treatment outcome, and thus can be used as a tool to assess the quality of operative techniques and pathological examination, which further provide insights on ways to improve the quality of care. Our limitations was the sample size was limited. It was retrospective in nature, and uncontrolled surgeon and pathologist. Also, the depth of invasion was not considered due to its recent implementation in the staging system. In the new TNM classification, which is the 8th, the extranodal extension has been added as a prognostic factor, but so far the nodal yield has not, maybe in the near future. Also, there is another term, which is lymph node density, which is not also involved in our study. Thank you.